Greetings to all the viewers of Physio TV. I, Dr. Prajakta Sahasrabuddhe, professor at Sancheti Institute for Orthopaedics and Rehabilitation College of Physiotherapy, welcome all of you to today's Physio TV session on physiotherapy approach for complex congenital heart disease, a case discussion. And I take a pleasure introducing my colleague, Dr. Lajwanti Lalwani, who's Associate Professor at Department of Cardiovascular and Respiratory Physiotherapy um, at Datta College of Physiotherapy. She has presented many papers at various national conferences and more than 20 publications in PubMed and Scopus Index journals. And this particular topic, that is congenital heart diseases, is happens to be her area of interest. So let's hear from the expert further. Over to you, Dr. Lajwanti.
Morning. Today I will be presenting physiotherapy approach for congenital heart disease case discussion. So coming to the case presentation, presenting a case of 2-month-old baby who was having complex congenital heart disease and who was operated on 30th October 2023 under general anesthesia with cardiopulmonary bypass for PDA ligation, that is patent ductus arteriole ligation, PA banding, pulmonary artery banding, and arterial septectomy, and was referred to chest physiotherapy. The effect of chest physiotherapy combined with lung recruitment manner on this patient will be discussed today. So these are the contents. Coming to the case history. This was a 2-month-old baby who presented in the OPD with chief complaints of, as narrated by her mother, excessive crying since birth, fast breathing, not feeding well, continuous episode of vomiting since birth, and forehead sweating since birth. Then baby was full-term baby. Weight was 2.5 kg. ANC history was mother was primary gravida and ANC history was uneventful and baby was delivered through C-section. There was no chromosomal abnormalities. After assessment and examination, patient was advised investigations like X-ray, ECG, and echo. Then the patient was diagnosed with complex congenital heart disease with DORV, that is double outlet right ventricle, large VSD, mitral atresia, PDA, and PH, and he was advised operation because he was having complex congenital heart disease. He was being advised stage wise operation. So mainly his main defects were double outlet right ventricle. You can just see in the picture both the aorta and pulmonary artery are, there is an opening from right ventricle and left ventricle is shrunken or less developed. Then he was having patent ductal arterioles as seen in the diagram. And there was VSD and pulmonary artery hypertension because of this. Was a complex congenital heart disease which will be operated stage-wise. So the problem list was patients with large ventricular septal defect and low pulmonary vascular resistance will ultimately develop pulmonary overcirculation. There will be overflow of blood in the pulmonary artery. Because of that, there will be changes in the lung paragram. There will be signs of congenital heart failure, including tachypnea, poor feeding, and pulmonary edema, which will be managed with diuretic, systemic afterload reduction, and potential nasogastric feeding supplement. However, long-term pulmonary overcirculation will result in irreversible vascular changes and development of pulmonary hypertension from increased vascular resistance, which will be problematic at its not only at cardiac level but also at pulmonary levels. So pre-operative assessment was done. Child was conscious. Weight was 2.8 kgs. History was narrated by her mother. There was excessive crying since birth, continuous episodes of vomiting since birth, and forehead sweating. Baby was full bed. There was no history of ICU stay after the birth. Vaccinations were done till date as per schedule. Then chest was examined, which has air entry decreased bilaterally. Temperature was ephemeral. Patient was 88 on room air, that is on room air. Then he was being given oxygen supplement. Heart rate was 58 beats per minute. Respiratory rate was 26 per minute. BP was 59 by 37 mmHg. JVP was not raised, pallor or absent. 2D echo reports suggest there was complex congenital heart disease. There was mitral atresia. There was small ASD, left to right shunt, large VSD, dilated MPA, and small PDA. This all suggests there was a complex congenital heart disease which will require multiple surgeries. Then this were the investigations done preoperatively. This is a preoperative chest X-ray of the same baby, which you can just see there is cardiomegaly, And also you can also observe there is mediastinal widening, and also increase because of increased pulmonary circulation over uh, there is shadow in the lung fields. Then the correction done was PDA ligation plus PA banding plus arterial subductum. What will happen because of PDA ligation? There will be stoppage. There will be which PD patent ductus arterioles will be there will be separations between pulmonary artery circulation and aorta because of PA banding, because there is over circulation of pulmonary artery. PA banding will decrease the lumen and will decrease the over circulation, which will be problematic later on. And arterial septotomy will help in maintaining the circulation. Because of because of septotomy, there will be flow of blood from right atrium to left atrium. Then post-operative notes where like midline sternotomy was done, PDA dissected and was ligated. Patient was weaned off cardiopulmonary bypass. Decannulation was done. Hemostasis was achieved. Post-band plus septotomy parameters where saturation was 74%. BP was 70 by 40 mm of Hg. Right arterial pressure was 40 by 5. Left arterial pressure was 16 by 8. And PA pulmonary artery was 36 by 18. Immediate post-operative, PP was shifted to ICU on pressure control mode of ventilation with saturation of 92% on ventilator. Heart rate were 146 beats per minute. BP was 59 by 37 mmHg and temperature was 36.1 degrees Celsius. Baby was assessed and on POD1, baby was extubated as baby was well. After few hours of extubation, baby was in distress. Now you can just see the post-operative chest X-ray, which suggests that the baby was extubated, but then there was distress. You can still see there is cardiomegaly, which because there was only this was stage 1 palliative surgery was done. Multiple surgeries are required, but and it because it was day 1, it will take time to resolve. Still, there was mediastinal widening and increased pulmonary vasculature markings. But on POD1, his baby went in brady, decreased saturation, decreased blood pressure, and the CPR was started. With 15 is to 2 ratios compression, injection adrenaline was given, pulse was 120 by beats per minute, BP was 40 by 20 mmHg, and ROSC was not achieved. Again, CPR was continued with same 15 is to 2 ratio. Then patient was intubated with 4 of cuff ET tube with pulse of 180 beats per minute, and BP was 82 by 58 of Hg and saturation of 97 on pressure control mode of ventilation, and then ROS was achieved. This was what happened to the patient. Now, patient was extubated, and again in the late evening, he was re-intubated. Ventilator settings after re-intubation were pressure control mode with respiratory rate of 30 beats per minute, FiO2 of 80% was needed, and a PEEP of 3 centimeter of H2O was given to the patient. This is a re-intubated X-ray when patient was re-intubated on the same day. Now, events which happened was he was operated on 30th and then extubated on the same day. But on the same day, in the late evening, he went in bradycardia. There was cardiac arrest, and then he was reintubated and was referred to chest physiotherapy on 1st November 2023, which was POD3. Now, because patient was referred for chest physiotherapy, we did an assessment. Patient on pressure control mode of ventilation, fine vitals was maintaining 90% of saturation, but then FI2 needed was 870%. Midline sternotomy was done, which length of scar was 9 centimeter. Chest examination assessment has on auscultation where there were bilateral capitations, Foley's catheter, PDA, and femoral line were in situ. This were the blood investigations. The main finding which we have seen post-operative was there was raised CRP because patient had some sort of inflammation inside. There was a surgery. There was re-intubation. There was an ABG finding where hypoxia, that was PaO2 was 34. Now, as the patient was referred to us for chest physiotherapy, we had careful consideration for each case differently because now the age of the infant, because the baby was only 2 months. The type of surgery was just a palliative surgery, but then the surgery has multiple factors involved. Patient was extubated and then reintubated. Now, what are the evidence? Because there are always a conflicting evidence related to chest physiotherapy in pediatric and neonate. So we looked at the evidence and we thought events and treatment plan was planned. Because it was a 2-month-old baby which was operated, was stage 1 palliative surgery, was extubated on the same day, reintubated, referred to chest physiotherapy on POD3. Evidence was searched and we came across chest physiotherapy and lung recruitment was planned. Now, why chest physiotherapy and lung recruitment? Now, if we plan for chest physiotherapy, CPT role is inconclusive, but still chest physiotherapy is used as gold standard for secretion clearance. But the drawback of chest physiotherapy are there can be desaturation, loss of PEEP while we do suctioning, or there can be arrhythmias. Now, lung recruitment is a procedure where we increase the PEEP, where here the main benefit is that it increases alveolar number involving an exchange of gases. Because you can see the patient has pulmonary overcirculation and there were changes in the lungs, there were changes in the lung vasculature. So there can be chances that alveoli don't get open. All the alveoli are not involved in exchange of gases. So LRM LRM can help in improving the number of alveoli participating in exchange of gases. But the problem here was in lung recruitment, there can be hemodynamic instability, there can be chances of pneumothorax or barotrauma if we give PEEP, which is higher. We have also looked at the evidences. There were actually no evidence giving a standard PEEP value up to this we can give to infant. But still, we tried this maneuver just because it will increase alveolar number involving in exchange of gases, looking at carefully monitoring the patient vital signs. Then on POD3, chest physiotherapy and LRM was planned for this patient. Chest physiotherapy techniques include vibration, positioning, and suctioning. It was given 2 to 3 times depending on the chest assessment and as per the requirement and clinical status of the patient. LRM was given, and you can just see the patient. This is a monitor of a patient. Patient was in pressure control mode of ventilator, and then saturation was 70% of FiO2 was required, and PEEP was 4 centimeter. Initially, the PEEP was 3 centimeter. We increased the PEEP to 4 centimeter, and there were no hemodynamic changes in the patient. Then again, we changed the PEEP from 4 to 5, and we waited for 1 minute. Still, the patient had no change in their uh, vital signs. All were hemodynamically stable, and there was also no increase. There was a steady increase in tidal volume. So we thought that there are alveoli are participating in exchange of gases. Then we went to PEEP 7. At PEEP 7, we found that this was our endpoint because there was slight decrease in blood pressure and there was slight decrease in tidal volume also. And this was our end criteria. And then we decreased in a stepwise manner. We increased in a stepwise manner and we decreased the PEEP also in stepwise manner like 7, 6, 5, 4, and then back to 3. Pre-treatment, the saturation was 92%. Post-treatment, immediately the saturation was 92%. Heart rate was 146 beat, which increased to 151 beats per minute, and BP was 60 by 41, which has decreased to 59 by 37 Hg. Then on POD4, again assessment was done. Patient was on pressure control, pressure support CPAP mode of ventilation. Now FiO2 was decreased to 50% and PEEP to 3. Then vitals where saturation was 94%, heart rate 155 and BP 79 by 52. Then chest was clear. In spite of this, we had planned giving prophylactic chest physiotherapy and LRM. Again, chest physiotherapy and LRM were repeated on POD4. Like we have seen, FiO2 was 50%, PEEP was 3. We increased it to 5, 5. Here we can see there was change in the tidal volume. There was decrease in the tidal volume. So we stopped here and then there was, sorry, no change in the tidal volume after 1 minute. And then there was increase in the, actually there was increase in the tidal volume from starting of 25 to 39. And then when the peak was, then again the peak was increased to 23. was again brought to 3, like stepwise decrease. So LRM was also given on POD 4, and then LRM technique, as we have already discussed. Then when we shifted to PIP 6, there was decrease in tidal volume to 22, as previously it was 39 and then it decreased to 22. So we have stopped and again stepwise decrease was done. Then on POD 4, FiO2 was reduced to 30%, and finally after proper assessment, patient was extubated on POD 5 and was shifted to bubble CPAP, then on 4 liters of oxygen using face mask. So on POD 5, on 4 liters of oxygen, CPT was continued, vitals were stable, and chest was clear. POD 6, baby on 2 liters of oxygen, chest physiotherapy was given. Here we have not given lung recruitment because lung recruitment is always given when the patient is on ventilator. Then chest physiotherapy was again continued, and POD 9, patient was off of O2 and 11, the patient was shifted to ward. So today, echo post-operative notes had shown that there was PDA ligation, arterial septotomy, and PA bending was there. Results are like POD 3, he was referred to chest physiotherapy where we planned for chest physiotherapy and lung recruitment. On POD 5, the patient was extubated and was shifted to face mask. And on POD 10, the patient was actually on POD 10, the patient was stable, but because just to monitor, he was then shifted on 11, POD 11 on in the ward from ICU. Results are, you can just see a change in the X-rays also. POD3, there was hyperinflection, there was increased pulmonary markings in the lungs, there was increased mediastinal cardiomegaly, and as the days passes, even this heart needed its time to recover. There were changes in the lung parameter. There was decreased pulmonary markings. There was decrease in the mediastinal thickening, and even the cardiomegaly was also decreased. So on has coming to the result, patient was on POD3 PC mode, on 4 pressure support mode, and on 10 room air. Saturations were increased from 90 to 92 to 94. Even PaO2 by FiO2 ratio was also increased from 48.57 to 110. The evidence, there is retrospective studies done by Rini 2020 on congenital stating that there is improvement in the compliance was observed and which was sustained for 8 hours after each recruitment. And we have also planned recruitment at multiple levels. So there are systematic reviews in 2021 on lung recruitment manual for reducing mortality and respiratory mortality in mechanically ventilated neonates. They concluded that there is very little limited studies. Current studies are unable to provide reliable evidence consenting to the effectiveness of LRM to reduce neonatal mortality and respiratory morbidity. Given the uncertainty of our result, a very cautious approach was taken with LRM using in this population until further research is conducted. There was a study published in BMC Pediatric in 2022, which stated that lung recruitment plus intubation, surfactant extubation treatment was effectively reduced the need of mechanical ventilator. And we actually were in the dilemma whether this will be good or bad. But then we have taken precautions that if we are not doing any good, we should not do any harm to the patient by closely monitoring during the session, because every time the PEEP was increased, it was made, there was an it was always a stepwise, and there was a 1 minute gap between each increase in recruitment, so that the neonate get the time, his heart and even his lungs get time to get adjusted to the increased amount of PEEP, so that we can closely observe the patient. This was LRM combined with CPT has benefited this baby. There was opening up of collapsed alveoli, thus improving the compliance, changing the pulmonary mechanics, and no significant hemodynamic changes were observed. And the strength and the weakness was multidisciplinary approach was there. We were trained in giving the PEEP technique Treatment was under close monitoring. We have generated an evidence for even one case of neonate, but the weakness was what is the maximum PEEP we can give, which is safe to the baby, is still was not clear because on POD3 there was some different amount of PEEP level and it changes on 4. Definitely it will change because of change in the compliance, but then still, what is the maximum limit of PEEP where we were unaware of? Translatory component, lung recruitment, agent to chest physiotherapy can be incorporated in routine clinical practice after generation of real world evidence for better outcome of patients. Take home message. This is a stage 1 procedure for palliative care. Baby will require multiple surgery. Chest physiotherapy is effective if we calculate risk is to benefit ratio. LRM can be effective in extubating patient. Monitoring patient during and after treatment is mandatory. If treatment done under multidisciplinary way, we can achieve the success. Thank you.
Thank you so much, Dr. Lajwanti, for such a practical insights into this interesting topic, which is not explored much. We would also like to hear more from you in the future. I also thank our technical team of Physio TV, and thank you so much for the management and principal of Sancheti Institute for Orthopedics and Rehabilitation College of Physiotherapy.